Hi, I'm Kevin McCann, President of the Canadian Association of Oral and Maxillofacial Surgeons. We are currently facing unprecedented changes in how we safely manage patients in our offices. All provinces have indicated that we should cease elective care. However, we should remain available to manage patients who present with emergency situations. We have also been faced with a deluge of information from a number of sources regarding the management of such emergencies. The CAOMS Executive Committee is attempting to distill this information in an effort to assist you with your decision making. We've created the following videos with input from our members as well as other experts in the field. I do hope that you will find them helpful. There will be a French translation available. However, I will leave the introduction of the French version to other capable individuals. We've also added a COVID-19 site on the website where we will post new information as it is received. Please check the website frequently for these updates. I do hope that all of our community is well and remains so. We are in for a bumpy ride. Please feel free to contact us with any questions or concerns. Thank you and stay healthy.
Monday, March 23rd. I just want to say that my name's Tony Shahadi. I'm an oral surgeon practicing predominantly in private practice with part-time university hospital practice in Montreal, and my role in this meeting is that I'm in charge of a subcommittee of the Canadian Association of Oral Surgeons that deals with communication and marketing. And the initiative behind this webcast is to facilitate the transmission of information to the members of our association and the dental community at large. We are here on behalf of the CAOMS to have a conversation with the clinicians from various jurisdictions in Canada to talk about the COVID-19 pandemic and to talk about the ramifications and implications that this pandemic has had on the practice of oral surgery and dentistry across the country. I'm very pleased to have with me today Dr. Brian Rittenberg, who is section head of the Oral and Maxillofacial Surgery Department at Mount Sinai Hospital, and also chief examiner for the Royal College of Dentists of Canada. I have Dr. Graham Cobb, who's chief of dentistry of the Calgary Zone Oral and Maxillofacial Surgery Unit in Calgary, Alberta, as well as Rana Richardson, who is an infection prevention control coordinator manager at the OMFS Clinic School of Dentistry at the University of Alberta. Guys, thank you so much for being with us this afternoon. As we discussed previously, I just want to state that for the sake of our listening audience, a small disclaimer that we are here having a friendly chat. We do not represent any dental or oral surgery regulatory bodies in a legal manner. So the opinions expressed in the discussions that we're going to have on the subject of COVID and clinical management of patients are friendly advice from us and should not be taken as a legally binding or practice binding information. You should continue to rely on your provincial regulatory body information, which are the primary sources of information for us today. And as you all very well know and have experienced firsthand, this is a tremendously rapidly moving subject, and the guidelines have rapidly evolved to where they are today and will probably continue to evolve as we see how this pandemic impacts on our society and our communities in different geographic areas. As everybody knows, in all of our communities, our clinical activities have now been in oral surgery and dentistry have been restricted to specifically emergency care. So I'm just going to throw it out there. Describe your role as chief of dentistry and the different roles that you play in your professional occupation.
Right. So yeah, I have a bit of a split professional personality where I do spend about 50 to 60% of my time in private practice and about 40 to 50% of the time at Mount Sinai Hospital in Toronto, where I'm division head of oral surgery. I work under our department head, Howie Tenenbaum, but also within the surgical services unit there. And it's interesting because when this broke, when our provincial regulator about a week ago gave us the red light, said that we're to stop all non-essential or elective care, my wearing my private practice hat got me concerned to some extent, but wearing my hat at the hospital even more, because I envisioned this flood of patients coming down to us at Mount Sinai Hospital, where during regular times that wouldn't be a problem. But one of the things I think we need to talk about is resource allocation within hospitals, and really what's appropriate, what is an emergency. Right. So the first thing that we did, Howie Tenenbaum and I and the chief of emergency medicine at Mount Sinai, is we came up with protocols of what is an actual emergency that needs to be seen through our emerge department, and what dental emergencies can be triaged other ways.
Right. Has there been the Royal College of Dentists of Ontario were fairly proactive in generating recommendations and guidelines that have been updated on a constant basis. Has there been a lot of communication between your institution and the RCDO on this subject?
There's been some. In fact, this afternoon, one issue that I brought forward to our registrar, who responded quite quickly, was, and I'm not sure, Graham, you can, and Tony, you can talk to us about what's happening in your provinces. But here, what the RCDSO did was they've asked practices within the community who have appropriate PPE, who can manage emergency care, to put their names on this list. And I pointed out, the fact that at this point in time, where COVID is really within the community, and we have to assume most people have it, that if you're going to render any care, any treatment to a patient that creates aerosols or even droplets, N95 masks have to be part of that PPE. And the reality is that, I don't know about your provinces, but there are very few general dentists who've been appropriately fit tested.
Right. So
there's going to be this roadblock that's going to be created, I think, in that regard. But the Royal College has been very responsive, and it's such a dynamic situation. We're getting blasts hourly as opposed to daily from them.
Right. Thank you, Brian, for that information and introduction. I think that for the sake of expediency, we're all in a position now versus perhaps last week where our provincial regulatory bodies have all published guidelines for us and different algorithms that we're using in terms of the triaging of emergencies. Graham, if I can ask you, how have you been able to, and your team been able to implement these guidelines, and have you been able to practically apply them across the board in the different streams of patients that you see?
Thanks, Tony, and thanks for having me on here. Just back to your first question about introducing who we are, where we come from. From my perspective, I'm a practicing oral and maxillofacial surgeon. I work, back and forth between two private clinics, which I share with some partners, as well as in the hospital. My official role with Alberta Health Services is in the chief of dentistry and oral health, not actually in the section of oral and maxillofacial surgery. So within that umbrella, I'm sort of managing for sort of in hospital or in Alberta Health Services facilities, ambulatory care facilities, some dental clinics that are, in the throes of, preparations for, the escalation plan of the management of the pandemic as it kind of rolls forward and evolves. So that's my sort of role in this situation with respect to how we prepare and preparing. So initially, most hospitals do have a pandemic response plan, and as do we in our section. The complicating factor a little bit is are we pandemic planning for like how to manage our own institution and our own employees, or are we pandemic planning to respond to how the community decides to behave? And those are two separate things. So for me, I think that some important context around the infectious disease physician, Dr. Katz, who did a webinar like this for Dental Corp, who's a professor at North York General, and he mentioned that we go through this phase of initially of containment when we talk about these pandemic diseases, and we're far past that. The next phase is planning around facilities and capacity, and I think we're still in that phase. And then the third phase of the management of the pandemic is protection of both the public and protection of the healthcare providers that are part of it. So I think for us, in Alberta, I agree 100% with Brian. We should be, encouraging dentists only to be involved in the assessment of people who are low or at no risk, essentially, or have been deemed to be at no risk based on screening questionnaires for COVID in your respective area. Those patients are the patients really that I feel like dentistry is limited to at this point in time. Now, whether they could see them and do some non-aerosol generating medical procedures, I think what we want to make sure that we do encourage is that they continue to be a part of the triage process and potentially even managing that group. At some point, Brian is exactly right. The community spread of the disease is going to be high enough that recommendation might change. But it's important that the timing of how those changes are rolled out are in coordination with the facilities that are going to have to manage the repercussions of that change like 2 days later. So I'm still in the position in Alberta of suggesting that, we try to coordinate between our college and our facilities our rollout plans, and everybody's really busy and everybody's trying really hard, and that's a difficult harmony to make happen.
Right. So I want to get back to the question of treating the COVID negative patient and the ramifications of that. But first,
yes, thank you for having me on. I am
Rana, can you tell us a little bit about what you do and what your role is in the context of what's happening
and
here?
In my role as that coordinator, I am responsible for creating all the learning and safety measures that affect all of our staff, our students, and our patients as well too. And I also run the oral and maxillofacial surgery clinic here on the clinic floor. I am a chairside dental assistant. I am also an RN as well. And so I have a unique perspective from both sides of medicine and dentistry. From a more hands-on point of view. Many dentists are struggling because they are now finding that in these uncertain times, those tasks that they relied on their staff to carry out and relied on their staff to be aware of current standards and best practices, they're finding that maybe now they're lagging a little bit. And I'm seeing this a lot in our dental community. I also own a consulting business, and I do consult in private practices, and oral surgeons are in that group as well too, in regards to specifically to infection prevention and control. And we are constantly, the minute I write a document, it's out of date. And that's currently because the landscape of COVID is changing so rapidly.
Well, in your hospital department, can I presume that you fully staffed at the present time? Are all your team members present and available at work? Or what's your employee structure at the present time?
Currently on campus here in our school dental clinic, we are closed. The University of Alberta closed us for students. There are no students attending our campus at all. They gave the directive at the tail end of last week, that all research labs that are not pre-approved by the deans of each faculty and by Alberta Health Services that are deemed as non-essential in this current push against COVID, those research labs have also been closed down. So we are running with, as far as seeing any patients go, we have changed our clinic structure. We are only seeing patients twice a week. We have a shortened clinic time to allow for maximization of our very small stock of personal protective equipment, which has been an ongoing battle for me since the end of January. And over in the hospital clinic, they have changed their way of booking patients and the types of patients they're seeing, meaning that they are moved completely to seeing only emergent cases. But over there, they have challenges as well, too, because there are patients, for example, who are waiting for a heart transplant, who are waiting for hip replacement, and those patients still need those surgical clearances in order for those more urgent procedures to carry forward. And the dental clinic over across the street in our hospital is involved in that. So their staff, of course, were limited. PDC came at a bad time for us, which is the Pacific Dental Conference. There was a mass number of people from dentistry that were at that conference, and it took many of our key players away from work for the first 2 weeks of this management. They're back at work today is the first day. Many of them are. We still have many staff members that are trapped outside of the country and haven't been able to come back. So as far as our staffing levels, we are running a skeleton crew. We will have one operator with all of our dental specialists, section heads on call to help triage any treatments. And as far as any staff members, it's we're assigning a skeleton crew on each day. We basically have one person running our central sterilization, one person who is in charge of doing nothing but cleaning operatories, so moving in behind the primary dentist and the primary dental assistant, and we're running more of a strict, streamlined, very, very narrow focusing on emergency patients only.
And how... so the emergency patient, by definition, that have generally been adopted across the board are facial trauma, life-threatening infections, intractable pain. Are these the definitions that have generally been respected in your area?
Yes, absolutely.
Okay. Have you had assistants or secretaries or nurses that work in your department come to you and express concern over being in the workplace in the context of the types of patients that you're receiving? In terms of risk to them personally.
Many of them. I kind of hold a traditional school nurse role, if you will, and many people will come to me with their concerns. And the people that we're seeing are people who fit the high-risk category profile for contracting the disease. And early on in it, we were given really strong guidance, and it was, anybody who was over 65 years old and had any other health comorbidities, any lung issues are a big one, cardiac issues, diabetes, those kinds of things. So I've had those kinds of employees, including instructors, dentists, who have expressed those same concerns in regards to being involved in our emergency clinics on our floor. So for our institutional here at the university, we are exceedingly cautious, generally speaking, and in that regard, we have advised any of those individuals who fall into those higher risk categories to not be involved in our emergency clinic care. And this has also occurred over across the street in the hospital, but then again, they're running into challenges because they're seeing far more patients than we are here in our clinic in relation to those surgical clearances, and their dental trauma is basically is going directly to that clinic at this point.
So I thank you for that information. I'd like to turn the attention to trying to address the questions of the algorithms that have been presented to us in terms of the management of patients for the interest of clinicians that are listening. So let's talk about the patient who's COVID negative based on history and based on symptomatology. And I'll just make the following statement that most practitioners, dental and oral surgery practitioners that are triaging patients, are interviewing these patients to ask the necessary COVID screening questions. And they're also interviewing patients to assess the degree of gravity of their conditions. And in the majority of instances, we make every attempt to defer treatment down the line as long as it has no danger to the person's health, correct? What I've been confronted with is a situation where I've had a patient with a facial infection who's required a dental extraction. And we can all envision this scenario where it would be necessary to remove the tooth in a COVID negative patient in an outpatient private dental facility with an aerosol generating procedure. Is that something that would be reasonable to undertake? Maybe one of you can.
If you had asked me this question 2 weeks ago, I probably would have had a little bit different answer than what I have today. Given what we know about the transmission of the virus, and I think it's important to make that distinction. For example, using an air-water syringe to dry off the surface of a tooth is not as invasive as might be using a surgical handpiece to remove bone and or section a tooth. With current knowledge today, I would say that that's not safe at this point. We can't say whether or not that person, even though we've screened them with the appropriate questions, even though maybe we've done a little bit of a physical exam, doing auscultation, those kinds of things, taking some vital signs, that patient could very well be in what has now been described as up to a 14-day incubation period and asymptomatic. And so I think that this is, and goes back to that, making sure you're choosing your most healthy individuals to be involved in patient care on these particular cases that might be aerosol generating, and donning appropriate PPE. And I can tell you here in the province of Alberta that there are very, very, very few dentists who can or do have N95 mask stock in their practices, or even can purchase it at this point. Here, we currently cannot purchase anymore. So the masks that we do have, we are rationing and using with very, very thoughtful plan. And it's, we're unclear about whether more supplies, if and when they will become available. And at this point, I just had an email this morning from Alberta Health Services reaching out to the community to have everybody report their stock of PPE that they are in need of. And so I fear that the lack of appropriate personal protective equipment, or the inability to purchase it, is going to be the limiting factor in practicing dentistry in anything other than a triage method, with no aerosol generating procedures in the community.
Right.
I think PPE is going to play a huge part in this.
If you have a COVID negative patient who tests negative for COVID testing, would that change the situation? But let's turn things over to Graham for now.
Yeah, I don't disagree with anything Rana said. I agree 100% with Rana said, but I think it depends a little bit on the hat you wear, when you're answering the question. If we're answering the question only in the sense of protecting, the dentist or the one employee in that particular moment in time, you would say, well, let's just offer the best of available protection. Why not? We should just wear a respirator suit and a hazmat suit, and we'd all be protected. That would be the best situation, but we have to put it in context of the public health problem, the facilities that we have available, the PPE that we have available, and we also have to realize that Nova Scotia might have 1 or 2 cases in their entire province, and Ontario has 400. So the amount of community transmission that's likely in one area is different than in another. So I might say, I think that oral surgeons still should be managing those that are COVID negative, asymptomatic, pass all the screening tests with appropriate PPE, should be seeing them in their office when they've failed all attempts at medical management. And then I think that we won't treat things the way we normally do. So we make some decisions around treatment that is going to be what we would typically not do and might be considered compromised, but in the context is not. So instead of doing an extraction, if you think it's going to turn into surgical, you might just put a Penrose drain in the vestibule next to the tooth, drain it out, and continue your antibiotic management. You might do something different like that. And I think anything like that potentially will offload providers that are further down the line is still a valuable asset in the global kind of community public health response. So the who and when we go to N95s for all exams versus all aerosol generating procedures versus only seeing people in hospital-based facilities, that progression might happen, and it might happen in a different frequency amongst provinces. Part of the confusion is that there's a massive information dump out there right now, and we all have access to it all. So what's going on in the UK, we have access to. What's going on in China, we have access to. And there's been over 100 publications on COVID in the last 6 weeks. right? Which is not typical for, our typical standard of what we consider quality evidence. We all need to take it in context of our local community, our regional facilities, our PPE lines and stock, and all of the end users of whatever flow charts we establish as to where we're going to recommend people go. Those little intricacies are tough things to work out in short order.
Can I just recap one element of what you said for the listener? Number one, in terms of the amount of data that's available, as you said, most of us are very, very busy, and many of us in the roles that we occupy in our professional and administrative lives will go into and delve into that data as it becomes available to us. But I would say that 99.9% of people are dependent on provincial guidelines as they come out, and unfortunately on some interpretation of what's out there on social media, which is not entirely reliable. But so if we get back to provincial guidelines, I'll just say that at the present time, Tony Shahadi is an oral surgeon in his community who deems that it's absolutely necessary to intervene on a patient in an aerosol generating procedure. My goal would be to try to get the patient COVID tested, in other words, to confirm that they're not positive for COVID. And if I have that information, I could then proceed with appropriate headwear, a surgical hat, surgical goggles, a regular surgical tie-on surgical mask, perhaps with a face shield if possible, a surgical gown, and technically speaking, if I could get an assistant to come in to assist me, it would either be an assistant or, as has been done in some offices, my partner in practice would come in to assist me on this procedure. And we can then, according to the letter of the law and the latest recommendations by the provincial authorities, proceed with that kind of surgical procedure according to current standards, right? And as you're mentioning, those may change. It may be that they'll evolve into, in an ideal world, I'd rather be wearing a hazmat suit when I'm doing that kind of procedure. What I'd like to turn it around and say, I'll wear the hat of a clinician in private practice, where I'm confronted with a scenario of a patient that I believe absolutely needs to be referred to a hospital center. And I will turn around and say that you, Brian and Graham, are people that sort of manage the floodgates, if you will, and manage the door to get into the hospital. If I can ask one of you what your criteria are at the present time and how stringent have they been observed in terms of what you've seen either your residents or attending staff manage in your hospitals?
I think the big concern that we had here in Toronto, particularly at the downtown hospitals like Mount Sinai where I work, was all about resources and waiting for, as we're following the trajectory of COVID here in Toronto and Ontario and Canada, which is essentially tracking right along UK and other European centers, we're waiting for that flood. And so what we've done here in Toronto, at least, are two things. One is we have created a new triage system within our emerge department, which I think may end up being appropriate post-COVID as well. We're really in a busy downtown Toronto emergency department. The patients that the oral and maxillofacial surgeons are getting paged for now by a triage nurse would be those with suspected facial trauma, life-threatening infections, intractable pain, and even that sometimes is questionable, or uncontrolled bleeding. What we've done, and this is important for the community oral surgeons out there, I'm on call now at Mount Sinai and found that the dump started about 3-4 days ago. It started by community surgeons essentially just sending their patients down to Mount Sinai. And what we've done through our Ontario Society is put a blast out today asking surgeons in the community to please connect with the attending surgeon who is on call at the hospital for a variety of reasons. One, resource assessment. I mean, before I accept a patient from another hospital on transfer, I need to make sure that our hospital's bed situation is appropriate, that our OR situation is appropriate. And I think that's really, really critical because there are a lot of community hospitals that may not have the same influx of critical COVID patients or other medically compromised patients draining those resources. I think that's really important. I think one last thing before I let Graham just add to what I've said. The one issue, Tony, with testing of any patients. And I just got off a Zoom call before this meeting with our surgical services group here in Toronto. And there was a suggestion that patients who require treatment, pre-radiation oncology patients who need teeth removed urgently, there was a suggestion maybe we get them COVID tested and we don't do any treatment till they're COVID negative. Problem is, current testing is a 96-hour turnaround, at least here in Toronto. We don't have the 45-minute test. And so you've got to rely on getting your hands on the test, number one. Number two, the patient's got to isolate themselves for 96 hours and really not see anybody else. We have to rely on them doing that before we can drop our guard a little bit to treat them as COVID negative, which is a bit of a problem.
Right. So, Rana, just as an infection control specialist in your department, tomorrow morning, your team has to do an incision and drainage on a known COVID positive patient who's symptomatic. How would you manage that situation?
That patient would be, we're at a luxury because we have access to Alberta Health Services screening staff that are in the lobby of our building. So every patient that they've limited foot traffic and the flow of patients through our facility. It's all locked down. They have to all enter through one door. There is a team of screeners down there, and they have patients clean their hands and don a mask. They do the questions screening, the COVID question screening with them on the floor. They then would call up and let us know that they have a patient downstairs that's coming to our clinic that has popped on some of those COVID questions. We have a staff member that would go and meet that patient in the lobby, bring them up to our clinical areas and escort them into one of our enclosed operatories. We do have currently the ability to, I'm a N95 mask fit tester, so I'm here to any of our practitioners that are operators and our RDAs as well. We will fit test them for N95 mask usage and have them don the full meal deal, meaning hair cover, facial shield, N95 mask, and a gown. And depending on what procedure we're doing, it would be either surgical or examination gloves. And so we do have, the patient would come in and our staff would be prepared with the appropriate PPE, and we are prepared to do that AGMP in the least invasive and most thoughtful way possible to help manage that patient at this point.
Can you talk to me about room ventilation and what your interpretation is of a negative pressure facility? Because that's something that's been talked about as a necessary or an ideal scenario for the treatment of COVID positive or COVID risk patients.
I think it's important to know that the rules surrounding what a negative pressure room, particularly for a surgical OR, is are very strictly outlined by CSA, Canadian Standards Association. And so with a negative pressure room, what we need is for the internal pressure of that room to be basically, it's a downward flow, and that all of the air exits the room. And we have no of the external air from the external environment outside of that room coming into that room. So if you can imagine, it would be the room that when you open the door on it, there's wind blowing in your face, or it feels like there's wind coming out of that room. And that's what a positive pressure room is. So it's pushing the air out of the room. And with a negative pressure room, this is what we use for our isolation rooms, for our aerosol. For example, if we have a patient who's in hospital and they have tuberculosis and we're going to put them in a room on the ward, they need to have that negative pressure room. And what it does is it prevents the germs that are in the room from exiting out. Now, there is some concern over whether negative pressure or positive pressure is appropriate in this particular instance, because what we are describing is seeing a patient in those operatories that is the source of the contamination, that is the source of that we're trying to protect the rest of the environment from. So I think that there isn't any clear guidance outside of what standard guidance, what standard practices are for designing ORs. Outside that are like we don't have guidance specific to what this COVID risk presents in those challenges.
Would it be fair to say that it's extremely unlikely that there's anywhere in Canada in the private sector where one of these ventilation controlled rooms exists?
I would say that's accurate.
Is there one that you would say is more ideal in the context of aerosol generating procedures for COVID patients?
In my mind, keeping the contaminants inside the room and thus being a negative pressure, in my mind, scientifically makes better sense than does a positive pressure room.
So for our private practice, we are essentially limited to asymptomatic patients, all screen negative. We're going to triage people outside of our office, not even inside the door, repeat the screening questions, thermometer checks, treating it just like the hospital entry is, just like Rona described, they're doing at the front doors of the hospital. We're going to escort the patient directly to an emptied out operating room, do our evaluation, potentially do a non-aerosol generating procedure, and essentially escort the patient back out again. Hand sanitization and masks before they come in, and back out again with masks on the way out. That's our current strategy and plan for the negative patient, just in our own sort of private practice clinic setting, of course, with all the appropriate PPE. As far as coming into the hospital system, we have different levels of triage. So we have triage for the asymptomatic screen negative patients, and then we have triage for the at-risk or COVID positive patients. And they actually come in through two separate streams with two separate protocols. And our request is the same as what Brian put forward, is that all transfers come in with a doctor-to-doctor contact with respect to the referral. We're not taking walk-ins, and our expectation is that we're hoping that dentists and oral surgeons who are only restricted or only limiting their practices in the community don't send people without giving proper direction on how to be part of that intake solution. And then for aerosol generating medical procedures, we are only set up in our operating room theaters within the hospital, and each of our hospitals have two rooms at each site. And those are the only places where we are currently doing those procedures. And I think that we are evaluating facilities for aerosol generation in other sites, including some of our in-hospital dental clinics. But IPC approval needs to happen before those, even though we've set up the protocols for it, just like the emergency, Brian's describing their emergency room setting up at different intake scenarios, IPC is extremely busy trying to arrange for intake scenario lines at the emergency room, whether it's for all of surgery to have a place to assess people before bringing them in for operations. So once those things are sorted out, I think our dental clinics will kind of come in line with that. But until then, all our AGMPs are being done by either oral surgeons or pediatric dentists with hospital access to the operating room for those procedures.
Maybe you can touch on the subject of screening and how it possibly has evolved as a situation in Toronto.
Yeah, well, for those of you who may or may not have heard, in our province, essentially, as of today, is in complete lockdown, or as of tomorrow at 11:59. All non-essential services, medical or otherwise, outside of the things that we do, are locked down. And that is sort of going along the lines of where we're at in Toronto and Ontario, probably British Columbia as well. And fairly soon, this will follow in other provinces, in that we're into a situation of community spread. And so whereas last week and even up until, through the weekend, our screening involved the typical travel questions and whatnot, I walked into the hospital this morning, the screening has now evolved to, are you symptomatic? So the assumption is now being made, and I'm not sure what the scenario is in Alberta or in Quebec or anywhere else, is that everyone's COVID positive. And I think the message needs to be, particularly until we have these rapid turnaround tests, we need to treat every single patient as being COVID positive. And so if we're rendering any treatment that is an aerosol generating procedure, I think we need to protect ourselves and our staff and patients that will follow that patient who's being treated. And just to make the assumption that these patients are more than likely COVID positive. If not now, fast forward 2 or 3 weeks, and we'll certainly be at that point.